Thanks very much, Sean. Excellent talk. Excellent tips for those of us who have patients and we're trying to deal with vaccine hesitancy on how to approach them. We do have a lot of questions, so if all of the panelists can come back on camera. We have questions for each of you. We have, with all sessions, we probably have more questions than we have time to answer, but we'll get through the ones that we can. So we'll start with one for Michelle, a question about whether herd immunity helps with outbreaks when lack of vaccination is below, for example, 10%.
So it does. The key issue is what level of vaccination coverage we need in order to obtain herd immunity for a given disease. And that's going to be a function of two factors. The first is the R0, or the reproductive number of the disease, which is how many new cases we get for each existing case within the population. That's a measure of the infectiousness of the disease, and the more infectious it is, the greater vaccination coverage level is required to achieve herd immunity. And the second factor is the effectiveness of the vaccine. The more effective the vaccine is, the lower vaccination coverage we actually need to get effective herd immunity. So as you can imagine, both of those things vary a lot from disease to disease. And for some diseases, it does matter whether we've got 90% or 98% vaccination coverage. And just to give you a sense of the range, for measles, as I talked about, the percentage of coverage that we need for herd immunity is up around 95%. That's because the R0 for measles is between 12 and 18. It's extraordinarily high. For polio, in contrast, it's around 80 or 85% of the population that we need vaccinated to get herd immunity. That disease has an R0 of 5 to 7, so a lot lower. And for influenza, we just need about 40% coverage in the population because the R0 for influenza is less than 2.
Great. Thank you very much for that complete answer. A question for Dorit. If an exempt child becomes a source of vaccine preventable disease, can others seek legal mandate to get these children vaccinated to protect their own kids?
Generally, you cannot go to court and ask for an order to get another person's child vaccinated. There's some exceptions. For example, if you have a father on one side that's remarried and the mother on the other side, and one of the parents opposes vaccines and the other one wants the child vaccinated, then the court might side with the vaccinating parent. That has actually come up in a number of cases. But usually you have to be either a guardian or the state stepping in to require vaccination. That said, another option is if someone doesn't vaccinate, the child gets a vaccine preventable disease and infects your child, another option is a tort claim saying, you acted negligently, my child was hurt, you should compensate me.
Great, thank you. Another question for maybe Michelle and Sean or Todd. I'm concerned about the impact California's laws may have on the willingness of physicians to accurately report adverse events encountered after vaccination. Please comment on how physicians who observe a potential serious vaccine adverse reaction that is not already enumerated by ACIP should proceed.
Yeah, I saw that question. I'm a little perplexed by the premise, so I'll see if others have a different interpretation. I don't necessarily see a connection, but maybe it's helpful to clarify that the California legislation, it had these processes in place for the Department of Public Health to kind of go after physicians related to vaccination, but that was for physicians who were writing a lot of exemptions. It was not triggered in any way by reports of vaccination reactions. So to me, I don't see a connection, which is reassuring.
Great. Anyone else have a comment on that? No? Okay, excellent. A question for Sean. How do you suggest approaching vaccines with shared clinical decision-making recommendations?
Yeah, that's a really good question. So that's one of the issues we've run into with some of these discussions around motivational interviewing. And many of the, for example, medical students, nursing students, et cetera, are being trained in the area of shared clinical decision-making, which is fantastic. But on the other hand, shared clinical decision-making is really designed for preference-sensitive decisions, meaning that there are equally good options depending on what the intervention is. The example I use, not being an internist, but it's familiar to a lot of people, is should you get heart surgery or should you get a stent if you've got blocked arteries? there may be pros and cons to both. And so you work through with the family on shared clinical decision making. The vaccination decision is, vaccines are the standard of care. The science is overwhelming that the right thing to do is vaccinate. It is not a preference sensitive decision. So in that sense, really doesn't fit within that framework. So what we're trying to do with motivational interviewing and other communication frameworks that people use is help convey the facts around vaccines so parents understand those. But it really is not a place for shared clinical decision making.
Great, thank you, very clear. Dan, we had a series of questions about the bracelet. So I'm going to ask them all together, and if you want me to repeat some of them, I will, because there are quite a few. Mostly centering on practical things like, might they be passed on to different children? Could there be a stigma associated with not having a bracelet? If it became something like that was needed for access to schools, could there be a black market for it if it became sort of widespread and associated with desirable things? And then a very practical one about that I'm sure you've dealt with, about the possibility of a choking hazard.
Yeah, I'll start with the first one. So obviously that is a question that we've addressed, and the design of the bracelet is such that the closure can't be opened by the child, number one. So that makes, that reduces that impact. It's also important to know that these bracelets, these beaded bracelets, are widely used within communities. So lots of experience in moms on how to use them, how to take them on, how to take them off. For some moms, if they, of course, they're all voluntary. If the moms wanted to, they could place the bracelet on the child's ankle as another option as well. The other questions, hard to group them all in sort of one answer. I would say we've done a qualitative study, which gives us a good indication of what we think the viewpoint within the community will be amongst moms and healthcare workers about how the bracelets will be accepted within the community. And so I think that gives us comfort in terms of how this is going to be, how the bracelets will be perceived in the larger scale quantitative study, which we have to conduct once COVID has allowed us to do that. I think in terms of the black market comment, which is another one that we thought about as well, the immunity charm will be launched not without strong communications strategies. So for example, talking about the quality of the immunity charm, where the beads come from, how the beads are associated with vaccines, that beads have to be given at the time of immunization. And those messages will be reinforced by the ASHAs, for example, in India, or healthcare workers. So it's not such that you're just going to launch the immunity charm into the community without lots of communications and training around it. We have thought, however, about engaging women's groups, for example, in manufacturing the bracelets, so that they're locally produced, which gives us an additional sense of ownership within the community. The bracelets are produced in the community and the beads are provided at the time of immunization. So a lot of those questions, I think, are going to be addressed in the qualitative aspect of our quantitative study hopefully in early next year, fingers crossed.
Great. And there was a final question, which I think is going to be answered by the quantitative study, which is what percentage of parents increased vaccinations because of the bracelet system?
Yeah,
I think that's what you want to look at, right?
That's a $1 million question, and we would love to know that, and we should have known that by now, but things got delayed. So I'll invite me back in 18 months if we get started, and I'll be able to report on that.
Great, thank you. This is maybe a question for whoever wishes to answer it, because it's a pretty broad-ranging question about PSAs for other things. So question saying, I've noticed many PSAs in the last month or so on the risks of smoking and getting teens vaccinated against HPV in commercials or on network TV. They're quite shock value in format. I haven't seen these, so I guess I don't watch enough TV. But maybe some of you have seen these. The question is this a preemptive course to pay for COVID vaccination or even flu season?
I mean, I've had the opportunity to be involved, I guess, in feedback on some of these types of campaigns, and they're tested, I think, to see effectiveness. They're not necessarily just, they try and stay away from fear mongering or throwing down fear in data, but they definitely drive emotion and emote things, which are quite effective if you can get into the messaging that draws on emotion.
Hmm. I think it's a really important point, and I think it really ties to whatever the health condition is. So, for example, you know, in Pakistan, for example, where polio vaccination rates were really quite low, you know, one could argue the strategy could be that there should be messaging around preventing your child from getting polio. But polio is such a rare condition in many parts of the community because the vaccination strategy has actually worked quite well. There are pockets where it's not working. Adopting a campaign that involves fear of polio isn't going to drive polio vaccinations. You have to understand what the barriers to uptake are. A project that we worked on, it actually had to do with mistrust of the vaccinators. So it wasn't the fear of polio, but it was fear of the vaccinators. And mistrust of the vaccinators, I should say, not fear. And so the strategy was, how can we instill trust in the vaccinators, show that they're part of the community themselves, their mothers and fathers who have children also who have been vaccinated. So I think it's really important for us to develop effective communication strategies that are creative, but are aligned with whatever the perceived barrier is, as opposed to making assumptions about what we think fear of the disease will be. Because I think with COVID, we're going to have the problem where we have 80% of the population who are going to have a very, very mild illness. If we use fear as a way of driving vaccinations for individuals to protect themselves, we may have a disconnect.
The only thing
go ahead, please.
The only thing I want to add is that while I expect that any messaging about COVID-19 vaccine will draw on information from other campaigns, campaigns for other vaccines are usually done for that vaccine. And the goal when someone is putting out a PSA about an HPV vaccine is increase HPV vaccination to prevent cancer. So we always learn from previous experience in messaging, but they're not part of a whole.
I was curious just along those lines as to whether any of you are involved in discussions of what messaging would be around vaccination for the COVID vaccine.
Well, yeah, this is Sean. Peripherally, I'll say that, you know, certainly CDC is considering this. I'm working with our state health department as well. It's somewhat difficult right now because we don't, you know, we hopefully will have several effective vaccines, but right now we don't know what those vaccines look like. We don't know the safety profiles, et cetera. So it's a little bit hard to craft the messaging. But one of the things that I think is crucial that all are aware of is the importance of engaging communities prior to the rollout of the vaccine, to understand what are the concerns in communities that have, many of which have good reason to be skeptical about medical interventions, and understanding what the concerns are there so that there's engagement and a conversation from the start.
And what I would say is that it's hard to, we're doing this on the fly, right? So we don't have good information to inoculate people with yet because it hasn't been created and we don't have the trials and the phase 3 trials done yet. So we are going to be playing a little bit of reactive ball here, responding to some of the disinformation that's out there, which is already coming out. So I know their campaign's already just like what Stronger's doing, trying to get accurate information and dispel disinformation as it comes out.
This is me talking not as a legal scholar, but as someone who's active online in speaking about vaccine. One of the voices that we don't have on this panel are the people who promote vaccines otherwise previously to Shots Heard and Stronger, who are great to have with us, but are relatively new on the block. For example, Voices for Vaccines and Vaccinate Your Family, and they have been working on preparing messaging for it. In fact, they have some things out. That might be a place to look for starting for work on this. There's obviously a lot more to do as we get more information. But for example, they put out a video about how do we know, how will we know whether the vaccine is safe or not, and other information.
If I can just segue off of that, and I agree with Dorit, educational information is important, but at the core of what we do, at the core of everything that we're doing here, is leveraging trusted relationships. And we do that from the people that already have face-to-face established networks. And that's exactly what came out of Johnson's paper. We need to now all become advocates and all where our patients are, and they're online every day. And so we need good educational information to be armed with, but we need to leverage these relationships in a way we have not yet done.
Yeah, and I think just to maybe to segue into something, I believe it was Sean was talking about the importance of getting the right message from the right messenger for the right channel. I hope I'm quoting the right person for this. You know, I think the other thing to do is to look for other sources of how the information is being provided. There's a lot of mistrust right now in governments and even in science. We're hearing all kinds of information about unproven treatments. I think we have to look beyond even our medical voices to provide information about vaccines from other trusted sources. Those can be done globally or they can be regionalized. And we're doing a lot of thinking with WHO and others about how to better reinstill trust in science, which will be fundamental for the launch of a COVID vaccine.
So related to that, and I think you've all spoken to this somewhat, but just very specifically a question about what advice do you have for communicating via the web and or social media? The questioner adds, it doesn't always work to provide just facts, so how do you open the door so that a patient's willing to listen when you can't talk directly to them? Anything to add from what you've said already?
What we've seen from the volunteers that we have, and we're closing on about 900 people, is they want to make sure that they already have, a lot of them are busy people that are doing a lot of other things and are happy to get out there and advocate, but they want to have prepared, accurate information that is very relevant to the issue that's being brought up, because they don't want to do their own research and then come back. It's pretty time intensive to do that. But again, I think going down to the more granular level, and as Dan said, it doesn't have to be a healthcare provider. It can be what we're seeing in the US right now is all this attention being paid to community health workers and community health advocates, which are embedded in the community, already trusted. So it's about getting the right people with the right information, but that information needs to be up to date, easily searchable, and oftentimes on social media, easily cuttable and pastable. So that's what we found.
Great. Any other comments on that? Todd, a follow-up question for you about how departments of health can partner with your organization.
Yeah, I think that there's immense strength in, at the Department of Health level, at the community level, I think there's still real trust. I think when you get to the bigger health system level and government, that's where trust is really eroding. So I think there's ways of partnering and, again, sharing information and maybe working collaboratively, not just on social media, but even in community level campaigns, particularly in areas and neighborhoods that have really disparate health resources.
Another question for you, Todd, and for the group maybe. It's a comment and a question basically saying that there's constant repetition that human decision-making is not rational, but it is rational if you evaluate within context of what matters to the person and the consideration of risks and benefits that they're assigning. So, and comments, something that everyone in this panel knows, but it's worth repeating, that treating decisions individuals are making as irrational or wrong or misinformed disrespects the many factors that an individual may be using. So how do we better respond to hesitancy with compassion? And that's been covered a little bit, but if anyone wants to expand on that.
I'll hand it over to Sean, but I'll just briefly say, whether it's motivational interviewing or AIMS, it's about learning how to engage, communicate, do active listening. Motivational interviewing is all about working in that framework, but I'll turn it over to Sean.
Yeah, I would agree. I mean, I think the point we're trying to make with motivational interviewing training, and again, it's one framework among several that could potentially work, is to have that empathetic discussion so that you understand where the parents are coming from, you meet them where they are, and you convey information in a way that they are receptive to it, as opposed to becoming an argument. Because what you don't want is to have the back and forth. There are lots of pitfalls that you can get into in these conversations. And having been in primary care for many years, I had plenty of those conversations where it turns into an argument. And that's not productive for anybody. And so I think the idea of any one of these communication frameworks is that we have these conversations in a more productive manner, so that parents and patients are heard. And just to be clear, when I say that, you know, human decision-making isn't rational, I don't mean it's not always rational, and I don't mean to disrespect people's beliefs, but the point I'm making there is that our decisions as humans, we are not just purely, you know, basing everything on science. We have emotions, we have beliefs. Those things play a role in the decisions we're making. And so it's not all just about, okay, I have the facts and now I know what the right decision is. There are many, you know, there are many things to digest as we're making decisions. And there, you know, for most parents, these decisions are complicated, and they're influenced by many things besides just the facts.
Can I add a point? I think it's a very, very important thing you just said, Sean. I sit kind of in a unique position here as someone who's been involved in global public health for 30 years, and now in the past 5 or 6 years have been working with a large marketing and advertising company in the private sector. And I think, you know, if our company was launching a new vaccine for a new category of product, we would conduct a market shaping campaign. So well in advance of the launch of a new vaccine, we would launch a campaign that shapes the market, gets people thinking about the new product in the right way. That would be global, it would be regionalized, addressing the local thoughts and fears, whatever. And then well in advance of the launch of the vaccine, so we're not behind the curve. I worry that we're going to launch the vaccine, then we're going to learn about all of the fears that people have about it, that it was rushed, or that it's genetically modified, or that it's an untested or previously licensed technology. We have to get way ahead of that, I think, and doing some kind of a market shaping campaign in advance of the launch of the vaccine, I think, is going to be really important.
I couldn't agree more with Dan, and we're seeing that specific cultural and regional, and even within the US, think of the anti-vaccine movements with the Somali population or the Orthodox Jews, or some of the work I did with the International Pediatric Association when I was talking to people from Pakistan and Afghanistan. The risks were completely different as far as the disinformation that's being spread. There's pork in the vaccine. They're made by Americans. It's going to sterilize us. We're all going to go to hell. I mean, I wasn't even prepared for that. I came in with these preconceived notions of, oh, I know what the disinformation was. Completely different region, Philippines to, you know, Pakistan to the Bronx.
Yeah.
Great, thank you. Another question for Sean about, do you think you can engage in shared decision-making with parents about the vaccination schedule if they're willing to vaccinate, but have concerns about the complexity and volume of childhood vaccinations, which is a very, very common thing?
Yeah, so sure, I kind of addressed that in the chat box, but I'll cover it here. So I think it's somewhat of a question of semantics, because shared decision-making, when providers work with families around vaccines, they're using a lot of the principles of shared decision-making. But shared decision-making has its own body of literature within the scientific and medical literature. And as I stated, it's for preference-sensitive decisions where there's not a clear recommendation one way or the other. We do have very clear recommendations around vaccines that are based in science. And so when you're starting to go outside of those recommendations, you're really kind of flying by the seat of your pants. And so we don't really, like for example, with a lot of decisions that fall under the realm of quote unquote shared decision making, people will create these elaborate decision aids that providers can work with a patient to work through what's the best thing based on my own personal beliefs. Again, vaccines, there's really not a way to do that, because the schedule is what it is. That's based on science, based on thousands of scientific studies, expert consensus. And so when you're deviating from that schedule, you're really going out on your own, out on a limb. And so we don't really have the tools to be able to do that, because we are essentially by definition leaving the recommendations?
A regular nuts and bolts answer for our practice on that is, it's true, the data shows as soon as you go outside of the regular routine regimen for vaccines, you run the risk of not completing the series. Something we do in our practice is stay within the confines of the periodicity of the well visits, 2 to 4, 4 to 6, 6 to 9 months, and say, if you're going to space them out, which we do allow because we serve a lot of breastfeeding moms that would otherwise, I think, leave. So we don't offer that as a first choice, but if we see that that's the make or break for them and they're going to leave otherwise, we use that periodicity and obviously a very robust recall system within our EMR.
And just to be clear, the spreading out of the schedule, really there's no good reason to do that. And that we can talk about all the bad reasons that people do it, but it's probably more painful for children. It puts them at higher risk of vaccine preventable diseases, and there's really no solid reason to do it. So I just want to be really, really clear about that.
Yes.
Great. I have a question for Michelle about what the status is of other states potentially following California's lead.
So there was a lot of activity in this space, not solely because of California so much as because of measles, because we have had outbreaks both in the 2014-15 season and then again much more recently in 2018. There have been a lot of state legislatures around the country considering legislation to tighten things down, and as Professor Rice mentioned, that has led another couple of states, New York and Maine, to change their laws just in the last couple of years to emulate the approach taken in California and the other two states. There have been a number of other states that have tried and narrowly missed or not so narrowly missed in their attempts to go in this direction. And then when you look at the broader legislative landscape, interestingly enough, there's also a lot of bills being introduced to expand exemptions, and that's because the anti-vax lobby in states knows that these currents are circulating as we've seen outbreaks of measles prior to that, pertussis, and mumps. There have been pressures to tighten things down, so they've tried to get out in front of that. And so on a volume basis, there's actually been more bills introduced to expand exemptions than to contract them, but there's been more success for the bills to contract them.
Great, thank you. Another very practical question. We often see parents who are completely their children are completely updated on the immunizations, but for whatever reason, they don't want to do the flu vaccination. Just a practical question about like, how much do you in practice, or do you recommend pushing on that? Because a lot of times when I see these kids, I back off if they've given all the other vaccinations and are very diehard about this. It's usually my, aunt got it and, went into the hospital or whatever. And I don't want to spoil the chances of the other vaccinations, but I would love your perspective on that.
I'm happy to speak up on this because I think we
Sure.
aren't well equipped to discuss flu vaccine. I think we also buy into the general narrative that it's not that good of a vaccine. We don't discuss, yes, it's variable in its effectiveness, but even a bad, you're right, is better. Some protection, 30 or 40% is better than no protection. We don't go on with the additional information of what it can do, even if you get flu, having been vaccinated, what it does to reduce severity of disease and death. And we don't use narrative, right? Again, I reference back to when I've met people from families fighting flu, and I just tell the story third hand of a mom that came up to me with a picture of her 17-year-old varsity baseball playing son who never liked to go to the doctor, who said, "Mom, I think I need to go to the hospital," and was dead in 24 hours. I still get a chill telling that story because it's a real story of a mom who dedicates her life now to telling people, like, if I knew there was a chance that could have made a difference, I would have done it. I tell that story all the time. That's narrative, and it's powerful, and I can do that in 30 seconds.
Absolutely. Great. Well, I think we're pretty much at time. I really want to thank all of the panelists for excellent talks and a great discussion. And I will turn it over to our team for the next session. Thank you all.